The things that I think are most valuable are right now are really chronic condition outcome measures, blood pressure, diabetes control, things of that nature, and functional measures that help guide to interventions, like missing your PCP or specialist appointment, right? That information and data is helpful because it's an intervention that we could guide people to show up. And so it's a very clear line of action from data to intervention. So those are the kinds of things that I think are most valuable.
In this episode, Dr. Rob Fields and Rebecca Grandy continue their conversation and focus on data. What's useful and what's a waste of time? What data truly drives value? And why do so many predictive tools fall flat? You'll also hear practical strategies such as where to focus when resources are tight, how to build an ideal care team, and how to make your value-based program sustainable even in a broken fee-for-service world.
Well, and I will say I have a love-hate relationship with data, right? Like data-driven decisions are so important, but sometimes the data can just feel overwhelming. So I guess as you're thinking about, measuring, things that you implement, the data that you're looking at, like what data do you think is most important as we go through value-based care? I know that's a really broad question, but just really curious because it is so overwhelming, but so important at the same time.
Yeah, I think it's a great question because I think pop health and value-based care is often misled by data more often than led in the appropriate direction. And I think we have a tendency, the collective industry, to over-engineer solutions that just make logical sense. Example, well, let me answer the question first and I kind of go back. The things that I think are most valuable are right now are really chronic condition outcome measures, blood pressure, diabetes control, things of that nature, and functional measures that help guide to interventions, like missing your PCP or specialist appointment, right? That information and data is helpful because it's an intervention that we could guide people to show up. And so it's a very clear line of action from data to intervention. So those are the kinds of things that I think are most valuable. I think the things that are way overhyped in every pop health conference that I go to, 1 million vendors trying to sell you the best tool for predictive analytics on who's going to end up in the hospital. And I've made this mistake before, lots of times, unfortunately, back to trying not to do dumb things. But, vendors will sell you the newest, greatest AI-based predictive model on who's going to have a complication, who's going to end up in the hospital, who's going to cost more. And what I've learned over my career in pop health is that it's too dynamic to really do that well. And often the insights you get from that data are not helpful operationally. So, there was a time earlier in my career we worked with a vendor that was really excited about that combined claims data with publicly available data that you can purchase that helped us give some context around social determinants at the person level. Mm-hmm. So it might tell you a risk of being unemployed or, have housing instability, et cetera, along with claims. Because we thought logically, the social care gaps that we might have are more important than the clinical care gaps that we might have. Therefore, it should add to the predictability of the model. Well, a few things. One, it didn't. Claims do a pretty good job, and actually age and gender does a pretty good job of predicting, especially relative to the cost you pay for some of these models. So doesn't add that much, interestingly enough. Second is that it's okay, I could predict with a high degree of certainty who might end up in the hospital in the next 30 days. What was I going to do with that information alone without some actionable insight? Mm-hmm. So what happened is our care managers would call and they would say, what are you going to say? My computer says you might end up in the hospital in the next 30 days and you're driving, to the grocery store. You're like, what? Who are you? First of all, why are you calling me? It didn't make practical sense, right? So it is like, duh, right? We didn't think it through all the way of, that's great. The statistics are phenomenal. turned out not to be that helpful, right, from an intervention standpoint. So we had to marry it with other actionable insights like missing appointments. And then, so I think that's the other piece. And then the next piece that I think is from a data standpoint that I think is way overhyped is really well, there's a few things, but one is we tend to look at the top of the pyramid of risk. Who are my highest cost patients, my most complicated, and everyone's eyes goes to that first, right? Everyone that enters pop health makes the same mistake over and over again. And inevitably what happens is that they're not terribly impactable. These are patients that are super sick, unfortunately so far down the road that outside of palliative care and hospice, there's often very little you can do to actually lower that cost. That's first problem. Second problem is that they're never the same. The dynamics of who's going to be your high cost population is actually not a static number. It's not the same patient. Some of them are the same year over year, but many of them change. They had a terrible year, super high cost, and then they go back to being normal, right? There's that regression to the mean concept that, just the laws of nature have it such that when you take a large population of anything, it tends to regress to the mean. We tend to be average as a rule. And anything else is fighting against that pull. It's like gravity, fighting against that pull to be average. And so when you look at any snapshot in time, who's flagged as being high risk, they're not likely to be high risk later. And so you've wasted a lot of time, energy, and resources trying to prevent this outcome. In the meantime, somebody else took their place. And so inevitably what happens is that you fail to actually reduce total cost in your contract because you're busy chasing the high cost folks. But it's so dynamic that it unless you're providing care across a large enough segment or proportion of your population to actually move the curve, you're just chasing yourself all the time. And I've found that over and over and over again. I'm actually partnering with our Center for Healthcare Delivery Science at Harvard through Beth Israel here to actually study that. I don't think there's any data to look at the churn rate by risk segment, but that's one of the things we're starting to look at is how dynamic is it year over year to help inform how we think about pop health differently. So going back to the beginning, why I think outcomes like blood pressure and diabetes matter, because those are the things that hit double-digit percentages of the population. So if you can control hypertension at a rate that, people talk about, if you're going to solve one public health problem, it's hypertension. If you can do that from the whole system, we're all going to care for hypertensive patients differently. With RPM, with pharmacists, team-based care. So now the vast majority of the population gets to a better outcome. Then you can actuarially, you can start to move the curve because now you've taken on such a big chunk of the bell curve that inevitably it moves. That's how I was starting to think of, like, and maybe just say it like one sort of tagline, I guess, is like scale matters when it comes to pop health stuff. And anything else, I used to work with somebody who used to call things science projects if they were subscale, and everything else is just a science project.
Well, and I've never been at an organization that said we have all the resources in the world, we can do all the things. Right. And so thinking about sort of the biggest bang for your buck and some of these pieces that you were talking through, maybe it's not the highest risk at the tip of the pyramid, right? Because maybe, we should think, upstream or think, people who are rising risk, or let's focus on hypertension. If you had to prioritize for people who have limited resources, which in my experience is everyone, right? If you had to prioritize, let's say, the top 3 practical things that folks could focus on for value-based care, thinking about those clinical initiatives, what would those be?
So we're thinking clinical initiatives specifically. So I'm taking out risk adjustment and I'm taking out site of service, which are the 2 biggest things that probably have impact, right? Shifting people to outpatient and risk adjusting. But from a clinical perspective, I 100% think it's chronic disease management. It's the thing that's most scalable because the other clinicians you work with outside of the pop health enterprise that you have built, which to your point is often under-resourced. So you can get clinicians to understand hypertension control or diabetes control. And so doing that at scale is probably the most important thing you can invest in. Now, what that implies, though, is that you're adding resources to the typical primary and specialty care delivery of care. So I have a high intensity bias towards clinical pharmacists because I think of what
Love
they can
that,
do.
by the way.
I know. I figured that wasn't just for you, Rebecca. I think people know, but I assume that would resonate with you. But yeah, I have a high degree of bias primarily because they are the most skilled on medication reconciliation, medication access, interactions, side effect counseling and guidance, and then they can prescribe. And that last one is really powerful because potentially you could train others to do that. But the ability to prescribe and actually intervene in the moment in time when you're on the phone and engaging with the patient, where the outcome isn't another inbox message to a very busy PCP or specialist, that is immense power in a system. So when I say hypertension and diabetes control, it's not about browbeating the primary care docs to do better about controlling their patients or more education, which I think is not terribly powerful or effective. It's really about systems of care that augment what the regular system can do and to increase overall management and control. And I happen to think pharmacists are a really important part of that strategy. It's not the only way to do it, but it's the way that I have found to be intensely successful. And I think what is most powerful beyond med adherence and med management is the in-between visit interaction with patients to make sure they're taking their medicines regularly, because we don't know in the regular practice of medicine. Actually, we do know that most people don't take the medicines as prescribed. So being able to have that conversation and engagement in between visits is immensely powerful, and that's what we've observed in the models. We're just getting started at Beth Israel Lahey, but certainly some of the models, clinical pharmacist models we built at Sinai, showed pretty amazing results. And so that's my bias.
Well, and I'm going to dream with you for a minute, and then we'll bring it back down to something practical.
Okay.
So if you were to make your care team dream team, finances are not an issue, reimbursements are not an issue. Love that you're going to have clinical pharmacists. Who else are you going to have on the dream team?
Certainly nurses and social workers, no doubt. I do, despite what I said earlier about the predictive model, I think thinking about social determinants or social care, as I like to call it, as part of the operations feels really important. And so I think social workers are a big part of that. But I think as much of anything, I think roles of non-licensed professionals like care coordinators and pharmacy techs and others, I think are important. But so it's some combination of a coordination / coaching model, but in some combination of nurses, social workers, and pharmacists. And, physicians, sure, nurse practitioners, sure, but they're already there and there aren't enough of them. So I'm really not counting on that part of the workforce to really build the foundation of my dream pop health enterprise. It's these other team members. And if I could dream even broader, I think it's also about paramedics. And, as you know, we built, but it wasn't my idea, but learned a lot and helped scale the community paramedic program at Mission and at Sinai, and with some great forward-thinking leadership there at the time to design this thing. There's lots of power in these other non-physician, non-APP staff that are, in some ways, looking to do more, or not some ways, I mean very directly, looking to do more, in some cases expanding careers, nursing staff or paramedics that were being on the floor in the field in the traditional job is hard physically, but still can contribute a lot intellectually and from a patient care perspective. There's a lot of possibility here to expand and extend careers in a pop health enterprise with some of these clinicians.
Well, and now I'm going to bring us back to earth, and I'm going to circle back to the CFO conversation, right? Most of these professions, as a pharmacist, this is something we've been fighting a long time, is that in the fee-for-service world, we're not reimbursable in a lot of ways. I think there's some progress that's been made there. But as you're thinking about building this dream team and making the case to the CFO, what success have y'all had, I guess, as far as selling this vision and making it financially sustainable in the current environment?
That's where a lot of creativity comes in. There are a couple ways to do that. In remote patient monitoring, I think there are a couple ways. Certainly there are procedural codes, so it's still fee for service, but pennies on the dollar compared to more expensive services we provide. So there are fee-for-service codes for remote patient monitoring that can help offset some of that cost. I think a lot of the patients that we serve, even in a hypertension program, are also on very expensive specialty meds and things of that nature that are costly for patients, costly for plans, and many times for systems as well. So thinking about, our specialty care pharmacy if those patients got care internally, it's better for them because we can coordinate the care better. It's supported often by pharmacy revenue or other things that help offset that cost. These things rarely are enough to, make a margin for a nonprofit health system, but they're often enough to help pay for the program. And so that's all it needs to do, right? Because, your returns from a value perspective, as you know, are delayed by a couple of years. But if we can at least get the program to pay for itself and provide a good service for people in need, then it meets all the philosophical aspects of some of these, pharmacy programs, and also is what remote patient monitoring is supposed to do from a CPT and fee-for-service perspective. So you can get creative with the revenue model. I think most CFOs are fairly burned out on the prospect of this is going to pay for itself in the shared savings. Nobody wants to hear that because every CFO has been fooled by saying, we're going to lower total cost of care by 10%. We're going to get millions of dollars back on our shared savings arrangement. And they say nonsense, right? Because they have learned the same lesson that I learned, which is most of these things are fairly subscale and are not enough to create shared savings on the totality of the contract. You can prove it in a cohort, but as I said before, a cohort is dynamic and changes. So you proved it here. In the meantime, somebody else took their place and you haven't saved anything for the population. And they've all learned that lesson because they're looking at the numbers. And so we try to support the programs we build by other sources of revenue in the short term, knowing that it adds value from a total cost of care perspective. But it doesn't matter if it's not scaled. So my goal is, can we get it to pay for itself on known revenue? That's a lot more of a sure thing, enough that we can grow it and scale it. And then if we're successful there, the value-based piece will take care of itself. But I think starting from a different revenue model works better. I think most CFOs don't want to hear anything else than that.
I know, and the specialty pharmacy space has been sort of a hot topic for a while now, and how you can save money and make money there. All right, Rob. So thank you for all the insights and the great conversation that we've already had. So I now have some quick rapid fire questions for you.
Okay, I'm ready.
Ready? Okay.
Yeah.
The biggest buzzword in value-based care that you wish would just go away?
Well, it's a phrase, but I think predictive analytics.
Interesting. Okay. One book or resource that every leader should read?
I think the book Drive by Daniel Pink it's a good for leadership in general, but I think it's helpful for behavior change and knowing people a little better.
I'm writing that one down. Thank you. Hardest leadership lesson that you've learned in this space?
What, at the risk of repeating myself, but the moral argument is almost never enough.
Yeah, unfortunately, right?
Unfortunately.
And then what keeps you optimistic?
I think what keeps me optimistic, maybe ironically, is that healthcare is kind of a disaster at the moment. And I think a lot of health systems are looking at I think cautious, if not grim, outlook on supply and demand and how they're going to sustain themselves over the next 20 years. And I think that creates a ton of opportunity to think differently than we have in the last 20 years. And in particular, in the areas of value-based care and population health. That's what keeps me optimistic, is that there are only a few paths to solve the supply-demand mismatch problems and the economic mismatch problems of the industry today. And I think value-based care is one of them. And so I'm optimistic that folks will, besides pop health leaders, I'm optimistic that more folks will pay attention because they will have to. And so I think in the midst of crisis, what's that cliche, like never waste a good crisis, or however it goes. I'm sure I'm butchering it, but it feels a little like that at the moment. So just, I think, keep focused and keep thinking creatively, adapt your language, right? Because it's all about behavior change. How are you going to convince people? Listen to what the feedback is and adapt. I think there's a path.
Yeah, for sure. Value-based care, I truly believe value-based care and team-based care are the future of healthcare. I think the nitty-gritty and the nuances of how we do it, there's a lot to be figured out there still.
A lot to be figured out. There's a ton of opportunity in technology. That makes me optimistic too.
Yes.
A lot of ways that we can engage an individual patient into behavior change that doesn't require 1,000 costly phone calls from staff and new ways to engage. That keeps me optimistic too. I think we have opportunities.
Well, thank you so much for spending time.
Yeah, thanks for having me.
Yeah, it was good to see you again.
Likewise. And I hope things in North Carolina are going smoothly.
This has been the Move to Value podcast, powered by Chess Health Solutions. We hope you enjoyed this episode. To explore this episode further, or check out past episodes and resources, head over to movetovaluepodcast.com. While you're there, you can sign up for email updates so you never miss an episode. If you're enjoying the podcast, be sure to subscribe on your favorite platform and consider sharing it with your network or leaving us a rating or review. Thanks for listening.